Good afternoon, everyone. Thank you, AIOS, for giving the opportunity to talk today. So, I'm going to talk about IOL power calculations. Uh, Nowadays, the goal of surgery has changed from good visual outcome to good refractive outcome. So, that is actually where the role of good IOL power calculation comes in. So according to the study in 2017, there's still room for improvement as most surgeons even nowadays able to achieve the best target of 0.5 diopter in mostly 80% of the cases, and only a very less than 2% of the patient surgeons are able to achieve a target of more than 92%. So with newer methods, this target of 90% is still achievable. The newer biometry devices, which has now improved to like the latest IOL Master 700 with faster acquisition, improved keratometry, and less reliance on ultrasound A scans, and increasing the number of parameters to improve the effective lens position helps us in increasing the IOL power calculation accuracy. So the IOL power formulas can be classified based on generation, which is now obsolete. A more practical classification of IOL formulas is on the basis of the principle, which is a historical or regression formula, which are now obsolete. The Virgin's formulas are based on Gaussian optics, which can be divided further depending upon the number of variables they use, either 2, 3, or 5 or 7 variables. Then there are ray tracing formulas. Example is Olsen formula, and nowadays artificial intelligence formulas which combine regression analysis and neural network. Example Hill RBF and Kane formulas. So the recent studies also shows the comparison of these newer formulas as compared to the older formulas, and they tend to perform better than the older formulas. Why were these older formulas imperfect is mostly because of prediction in the error in the prediction of the effective lens position. Older formulas generally use two variables, that is axial length and keratometry. However, they tend to work well within the normal eye range, that is normal axial length and normal keratometry. But whenever the measurement falls beyond the normal range, the formulas they don't tend to do better. So we need to increase the number of parameters to be fed in to increase the accuracy of effective lens position. So one of the parameters that is most important is the anterior chamber depth, which nowadays most of the newer formulas are using, and there are other optional formulas which are also available, increasing the accuracy of the newer formulas. So the newer formulas which I'll talk about are Barrett-Sweet formula, Olsen formula, AVO, Hill RBF, and the Kane formula. The Barrett-Sweet formula is a combination of 5 formulas. Barrett Universal 2, which is for non-toric IOL calculation with keratometry values. Barrett Toric for toric IOL calculation. 2K is for post-laser vision correction formulas. And Barrett TK is for total keratometry, which is nowadays used in IOL Master 700. This is the free interface, Barrett-Sweet interface, which is available free online and can be used for IOL power calculation. Barrett Universal 2 is more than just a formula, as in you can see that in the picture, all these Hagees, SRKT, Holiday, they are single line code formulas. But Barrett Universal 2 is a 3000 line code formula and a still evolving formula. It is based on theoretical optics, Gaussian optics, as well as on artificial intelligence, and it uses up to 5 parameters. So increasing the number of parameters which are fed into Barrett's increases its accuracy. Various studies comparing the Barrett's with the older formulas, Barrett tend to perform much better than the older formulas. Another formula is Hill RBF, which is considered a method, not a formula, as it is based on artificial intelligence algorithm. The RBF stands for radial basis function. It is a mathematical model that combines pattern recognition and data interpolation. It is used in facial recognition and sensitive softwares like fingerprinting, etc. It does not rely on usual optical principles. Hill RBF version 3 is now available, and since it is based on adaptive learning, the more the data is fed into it becomes more accurate. So this is again freely available online software, which is version 3 available now. Kane formula, which is the newest formula based on theoretical optics, regression, and the artificial intelligence, and it is applicable to all excellence, and it is found to be superior than other formulas, even Barrett 2 and Hill RBF we are talking about. However, it is still not suitable for measuring in post-refractive cases. So multiple published clinical studies have proven Kane formula to be more accurate in all cases, including the Barrett's 2 as well as Hill RBF. There are 2 large studies, including 18,000 patients and 10,000 patients, which have proven the Kane formula to be superior to these other formulas. So this study by Melissa in 2019 showed the cane formula to perform much better in across all legs illness. So that is the most advantage of the cane formula, is that it performs really well in long as well as in short eyes, especially in the short eyes, because the study in JCRS, published in JCRS, showed that patients with IOL power of 30 diopter or more, in that cane formula perform much better than Barrett's 2. And as we always said ki Hofer Q should be used for the shorter eyes, that is not the case. Hofer Q is one of the worst performing formulas. We should use cane formula or Barrett's 2. So what is to be used in longer eyes? In longer eyes, the problem is overestimation of axil length. So this overestimation, initially when we were using Holiday 1 and SRK2 formula, there was Wong-Kop method of adjustment which had come, but this is also not a very good adjustment, which we nowadays we should avoid, and which we should use Barrett's Universal to Hale RBF or cane formula. Another method in longer eyes is to use the biometer Argos, which uses segmental measurement of the axil length. So for long eyes, the best methods are using Olsen, Barrett and Hagees, and to avoid Holiday and Q, and otherwise we can use Hill RBF and Olsen formula as well. For shorter eyes, what is the problem? Even a minor error in the prediction of ELP causes a major change in the IOL power. So shorter eyes is a major problem with calculation of IOL. So which is the IOL formula which has performed in various studies performed better? As I already mentioned, Hofer Q is one of the poorest formula which is to be used for short eyes. Always use Barrett 2, otherwise we can use Hill RBF and cane formulas. They tend to perform better. So across the various AC depth, various keratometry and various axil length readings, the formula that tends to maintain its accuracy is Barrett's. So special circumstances like bag versus sulcus implantation, every surgeon now or the other time do fall into this scenario when we cannot implant the IOL in bag. So in that case, we cannot just go ahead with our same IOL power. We need to calculate the IOL power, recalculate the IOL power. That is because number one is because of changes in the effective lens position, and second because of the change in the IOL material or the IOL A constant. So the Warren Hill has given this adjustment. Depending upon the IOL power, you subtract other minus 1.5 when the higher IOL powers are used, and you subtract 0.5 when the lower powers are used. So even after perfect calculation and using the biometric device and best IOL power, refractive surprise still happen. So a coefficient is required which can be used to adjust the IOL power calculation of the other eye. So that prediction that is 50% of the prediction error. So there are two major studies which have covered this, what should be the optimum adjustment coefficient. So according to the IOL formulas, the adjustment coefficient is changed. So if we're using Barrett Universal 2, 0.3 is the adjustment coefficient, and other formulas are mostly 0.5 adjustment coefficient is required. So to summarize, most surgeons up to 80% are able to achieve the best target, that is 0.5 diopter. 92% is achievable with modern methods. The best optical biometer, that is SWEPS OCT, is now available and should be used with minimal limitations. The newer IOL formulas like Kane, Barrett, Olsen, Hill RBF should be used for all range of axil lengths, and we should be careful when we are implanting the IOL in sulcus and not in bag. Thank you.
Thank you, Dr. Richa. Any questions from the house? Okay. So, I assume you have used some of these formulas.
Yes, sir.
And your endpoint is of Barrett.
Barrett's, yes.
And though it would be a slightly off the topic, but how about the machines which give you a Barrett's? Any comparison between the machines you have?
So we have IOL Master 700, so that is one of the best machine. We are using Barrett's 2 in that. Barrett's 2 actually it has the advantage because it is using multiple parameters, not just 2 parameters. So maybe people who are using still ultrasonic biometers, they will say that there is no advantage of using a Barrett's. But however, there are studies who have compared that even with 2 parameters, Barrett's perform much better than the older formulas. So going with Barrett's is always better, whether any machine you're using.
Another interesting thing which I saw was with Keynes, the one of the 5 parameters was gender.
Yes, sir.
So how does gender come into picture in the entire formula?
Sir, it is not actually exactly, I tried to read it in detail, but I couldn't find it. But I think because of the anatomy of the eye, the the relation between the antechamber depth, relation between the axial length, that is because of the correlation.
Is there any information regarding the same key? Lady, female and male have different AC depth relationships. Is there something like that in literature? I'm not aware of that.
So I couldn't find that when I was reading about the Kane formula, but I was just guessing that is where the gender is coming to play.
But it was there, so it was
Yes,
very.
it is there.
That was the most interesting
Yes,
part
sir.
of it. Thank you.
Thank you.
Actually, for sulcus implantation, something known as the rule of 9, what you said, it's fine. But if you are going to capture the IOL in the rexes, then you don't need
Then
to
you
change
don't
the
need
IOL
the
power
adjustment.
because the
Yes, sir.
ELP remains the same.
Yes, sir.
So you should keep in mind if you are going to capture the IOL, don't change the IOL power.
Yes, sir. That is one important point.
Sir, in biometric chromatic eye, it is okay to use the K value of the other eye if there is a corneal tear, you have repaired it and you have a chromatic cataract. Then what formula do you use to calculate that?
So we use either the K value of the other eye, or we generally use the K value of the other eye because this eye has caused. Like if we are able to calculate the K values of this eye with astigmatism, we use the K value of the traumatic eye. But if not able to calculate the K value because of the opacities, because of the quite damage to the cornea, then we tend to use the K value of the other eye.
Better to use a standard K, sir. The keratometry of both eyes can vary. So we use a standard K, 44 and 44.5 or 44 and 45.
If axial length is same, if axial length is same or the things are same ACD,
Yes, we can also compare that way, yes.
And some formula they are using CCT, male, female also. So one ESER's website, you can put the data and 4 or 5 formulas there. So they will give you what will be the IOL power. So then you can compare it. Barrett is the best, Barrett Universal 2 is the best. But still you want to go, then if extreme of eye, you can go to that ESER's website. Multiple formulas are there, put the data, they will give according to EVO, Barrett, all these formula. What should be the IOL power.
And the other important thing is the biometry. If you are not doing a good biometry, you give any formula, won't help. So explanation biometry is out of question. If you are doing a immersion scan, do it well. Because everybody might not be having this optical biometer. So it's imperative to do a very good this immersion scan.